Hi, my name is Taylor Krupp, and I am a nursing student at the University of Michigan, Ann Arbor. For my clinical placement, I was placed at the VA hospital in Ann Arbor, Michigan, stationed in the 6th floor telemetry unit. I am going to present to you a patient. My patient is an 80-year-old Caucasian male who is currently still married. His former job involved working on a construction site for approximately 15 years, but then moved on to work at a local meat industry where the patient worked for the remaining 20 years of his work life. Patient was directly admitted to the VA hospital after experiencing cramp-like symptoms in his right ankle while shaving, which progressively moved up through his calf. Believing that resting his leg for a night would resolve the issue, the patient woke up with limited mobility in his right leg as well as numbness and a tingling sensation. The patient immediately sought out to the VA for medical attention. Upon entering the facility, patient was admitted to a room but severely aggravated the same leg after striking his hip on an examination table while physicians were lifting him. Patient explained that there were no aggravating or relieving factors when it came to his initial injury, just that he believed sleeping it off would help reduce the pain. At this time, patient claims that he is suffering minor pain from the original incident, rating it a 4 out of 10, but insists that his hip injury, which was sustained after striking on the examination table, is a severe pain that the patient stated was brutal and completely shut down his right leg. Because of this, patient is considered a fall risk. Patient was administered pain medications by overseeing physicians to treat his injuries, but further neurological tests were to be conducted. Doctors performed examinations and tests including an fMRI, which highlighted a possible cerebrovascular accident that may have occurred 2 to 3 years prior of his current hospitalization. Patient states that he had not received any medical attention for this incident. While hooked up to an EKG, doctors noticed on March 9, 2015, that the patient was undergoing atrial fibrillation. Health history. As a child, patient states that he was physically and psychologically healthy and did not sustain any medical abnormalities or serious injuries until he had reached the age of retirement. During later adulthood, patient was diagnosed as a type 2 diabetic as well as suffering from cardiac issues related to an irregular heartbeat and arterial blockage. Patient is also currently diagnosed with hypertension, hyperlipidemia, atrial fibrillation, and mild edema. As for immunizations, patient is fully caught up and on top of all of his immunizations. Patient states that he has no known allergies to any medications or foods. Prior to this hospitalization, patient states that he had only been hospitalized one previous time, which was related to a work incident. During this incident, the patient severely suffered a rotator cuff injury at the age of 63 while cleaning and inspecting equipment. This injury resulted in the patient undergoing surgery to repair the injured shoulder. Medications. Currently, the patient is on 7 medications, 6 are pills and 1 is injected. Clopidogrel bisulfate, 75 milligrams, also known as Plavix, is used as a prevention for the myocardial infarction. Digoxin, 75 milligrams, which is used to treat heart failure. Furosemide, 40 milligrams, which is used to reduce extra fluid in the body related to patient's edema, usually stemming from heart failure. Lisinopril, 40 milligrams, considered an angiotensin inhibitor used to treat high blood pressure and to prevent strokes. Metoprolol tartrate, 100 milligrams, used to treat angina and to prevent future heart attacks. Metformin, the injection medication used to treat type 2 diabetes, and his final medication being atorvastatin, 20 milligrams, which is used to help lower levels of low-density lipoproteins, also known as bad cholesterol, and triglycerides in the blood, while raising HDL, high-density lipoproteins, which is known as the good cholesterol in the blood. Health habits. Patient admitted to consuming alcohol when he was younger, but never experimented with any illegal drugs or smoking tobacco. Patient does not exercise as much as he used to, which the patient believes has led to him becoming overweight. Patient used to be involved in a lot of physical activity while employed, but since retirement, exercise levels have severely decreased. Patient reports no problem sleeping as well as consuming healthy home-cooked meals and a nutrition level. Patient does not smoke and his main caffeine levels comes from his daily consumption of coffee. Patient explained that he uses no safety devices to help accomplish his daily living tasks. Family history. Patient explained to me that for the most part his family has been relatively healthy. The only thing that he explained to me was that himself and both his father and grandfather suffered from hypertension. Along with that, his 2 sisters both suffered from type 2 diabetes just as he does. When I brought up the possibility of a cerebrovascular accident, the patient stated that to his knowledge, he would be the only known case in his family tree to suffer from a stroke. Psychosocial data. Subjective data explains that the patient has no past history of any psychosocial disorder. The patient has been married for over 50 years and has 4 children who he is very proud of and grew up to be very successful individuals in his eyes. Patient explained that he grew up very poor, which led to him dropping out of high school in the 10th grade. Patient also explains that he cannot recall ever living around any environmental hazard or additional stressors. Patient also emphasizes that he only receives health care if it is 100% necessary. Review of systems. Cardiac. Patient explained that he hadn't been experiencing any recent chest pains or numbness other than that in his right leg. When asked about any history of heart disease, he replied that he suffers from an irregular heartbeat and a stent related to arterial circulation issues. The patient also informed me that he could walk normally with no pain before the injury, but after which he cannot walk without assistance. Peripheral vascular. Patient explains that he only feels pain and discomfort in his right leg, and this is usually while resting. Patient also states that he does not feel like he has any abnormal hair distribution, but did feel a numbing/cooling feeling at the region of interest. Patient's vitals. While laying down, the patient's blood pressure was 137/64 with a heart rate of 92 beats per minute and a respiration rate of 14 breaths per minute. While sitting up, the patient's blood pressure was recorded at 153/67 and possessing a heart rate of 96 beats per minute and 16 breaths per minute. Patient's temperature was 97.8 degrees Fahrenheit, which was taken orally. Performed physical exam 1, cardiovascular. Because this patient is being held on a cardiac-focused floor, a cardiac exam is essential to perform. During this exam, all 5 cardiac points were assessed and there were no abnormalities recorded. There were no observable heaves or lifts. According to the subjective data, patient explained that he has never felt any bounding pulses from his chest. Though I did not personally hear any abnormalities in the patient's heartbeat and rhythm, patient does have a history of atrial fibrillation. Performed physical exam 2, peripheral vascular system. Because the patient has a past history of cardiac issues and circulation abnormalities, a peripheral nervous system exam was needed. Upon inspection of the upper and lower extremities, patient possessed minor edema on the lower right leg. Along with this, the patient possessed very little hair on the upper and lower extremities, but had a great amount of hair in the anterior and posterior thoracic region. Palpation of all peripheral nervous points were felt at a 2+, with the exception that the posterior tibial point and the popliteal, which were both scored at a 1+. Minor hematoma was also observed on the anterior tibial regions on both legs, the right leg being the worst. Pertinent system number 1, neurological. After my patient's fMRI, doctors noticed that he may have had a possible stroke in the past. The patient was also complaining about pain and tingling numbness in his right leg. Because of this, a neurological assessment would be pertinent to perform. According to the American Stroke Association, a cerebral vascular accident that takes place in the left brain may result in slow movement or partial paralysis in the right side of the body, which could lead to an explanation while he was experiencing that numbness in his lower right extremity. Pertinent system number 2, integumentary. Because my patient is already showing certain problems related to his cardiac issues and poor circulation, such as edema and little hair distribution on his lower extremities, that would appear on an integumentary exam. It would be pertinent to perform this exam to help discover the beginning of a very high-risk problem for bedridden, limited mobility patients, pressure ulcers. According to the Journal of Wound, Ostomy, and Continence Nursing, hospital-acquired pressure ulcers are becoming a serious problem due to their high cost to treat and unnecessary pain to a patient. By performing an integumentary exam, I would be able to spot early symptoms of pressure ulcers to reduce this inconvenience on the patient and on the hospital.